So this is a post-marketing surveillance, which is a real-world trial. The reason to do that as opposed to a randomized controlled trial is when you do a randomized controlled trial, you have a very small slice. It's all people of similar age and similar disease and similar comorbidities. And it gives you an idea, does this drug really work or not? It has no impact on how it will work. And a lot of drugs that sound really cool and work really well in the lab don't work at all when you roll them out to real people. And so doing a post-marketing surveillance trial allows us to see how it works in the real world. And so that's the why of what we did. We have 50,000 patients we got from the Department of Defense. The reason we use the DoD, and it's not that everybody thinks it's a veteran administration, it's not. The military health community has insurance policy, and so it covers all the people who work in the Department of Defense. So we have 50% women, just like the rest of America. It looks like the United States instead of looking like the veterans. So, and they have an outstanding electronic medical record. The other piece of that is that because it's an insurance company, you don't lose anybody to follow up. If you just use one hospital, you can get sick, go to that hospital, and next week you can go to a different hospital and we lose you. When you use insurance, doesn't matter where you go. So we have a very high capture rate. So we're pretty certain that the data that we have reflects reality of how the drug is actually used and the consequences of that. So what we're looking at is the major bleeding rate that occurs in patients who have atrial fibrillation, and so they're on Rivaroxaban as treatment for that, and complicated by the presence of diabetes. So we start with a 50,000 patient cohort, and about a third of those people, 27%, have diabetes. And so that's the group we look at. The reason we pick diabetes is because it's a driver for adverse events, and it is a part of the CHAD score, the CHAD's VAS scores. And those are the scores that say, well, you should have an anticoagulant if you have AFib. And so it is a risk group that we want to make sure that there's a safety margin in, and that in that group, that the patterns of benefit and risk mimic what we saw in the randomized controlled trial. When you roll things out to the real world, sometimes you find out there's risk you didn't expect. And so that's why we have that subset. In this population of patients who have diabetes and AFib and on Rivaroxaban, we looked at the major bleeding rate, and we found out that it's slightly higher in the patient with diabetes. So the bleed rate in people without diabetes in this cohort is 2.5 roughly per 100 patient years. And we do that in a 100 patient year format. And the reason is because there are people in there who are on Rivaroxaban for 4 weeks, and there's people on it for 15 months. And you want to, your risk of bleeding is based on how much exposure you have. The risk of bleeding in the diabetic group was about 3.5. So a slight increase in bleeding compared to people who didn't have diabetes. The important part of this to put into context, though, is that those people are also at higher risk of stroke. And so when you start doing that analysis and looking at risks and benefits, we've done a prior analysis. We looked at the patients with CHAD scores and looked at their bleeding rate. And it's clear, the higher your CHAD score, the more likely you are to bleed. Also, the much more higher is your risk of stroke. And to put these numbers into context, the major bleeding fatality rate in this trial was 0.09 per 100 patient year. So about 1/10 of a person exposed for 100 years would bleed. If you look at the risk of stroke, and I use the CHADS-2 as the idea of what the risk is, it's 3%. That's 3 per 1 year. And so if you want to put this in a similar score, that's 30 per decade or 300 per 100 years. And the risk of death from the bleeding in this trial, and it didn't matter whether you had diabetes or not, it was the same across the board, is 1/10 of a person. So when doctors say, well, I'm a little nervous about putting that patient on an anticoagulant because they might bleed, the answer is this. You're going to cause 1/10 of one person to not bleed by avoiding the drug, but you're going to give them 300 strokes. So the numbers are really clearly in the favor of treatment, no matter how hard. Even though we know that your risk goes up with a higher CHAD score, the risk of stroke goes up so much that the risk-benefit analysis is persistently for that of treatment. The other things we found out is that the location of the bleeding looks very similar to the randomized controlled trial, mostly GI, and there is a slightly increased risk of GI bleeding with diabetes, but it's all under that context of the ultimate risk is still low. The risk of head bleed, and that's the bad one, is intracranial hemorrhage, was no different between diabetics and non-diabetics. So it's reassuring that we're getting the same types of results that we found in the randomized controlled trial. So if you've got diabetes and AFib, you should be on an anticoagulant, and the bleed risk will never exceed the prevention of stroke benefit.